doctor at the Children's Hospital in at Charité in Berlin. And I am very happy to co-host the webinar today with my dear colleague, Professor Johannes Hübner, who is the head of the Department of Pediatric Infectious Diseases at the Children's Hospital at LMU in Munich. And he's here on behalf of the German Society of Pediatric Infectious Diseases. He is an infectious disease doctor and a microbiologist, and he's an absolute expert in the field. And I'm sure that he will get some special insights from him. So welcome, Johannes. Very grateful you are joining us today.
Yeah, thanks, Louise. A short welcome also from my side. I think it's very interesting. I've been to Iran a couple of years ago and really liked the country very much. So a little bit of the medical system. So I think it's a great opportunity, and I'm very happy to participate here.
Thank you so much for joining us today. Yes, Louise?
So antimicrobial resistance is, as we all know, a global health problem. So it affects all of us, and I'm very thrilled that we are joining here together, doctors from Iran and Germany, in order to exchange ideas and knowledge on that important topic. And today we would like to discuss the treatment of antimicrobial resistant gram-negative infections. And we would like to make this webinar as interactive as possible. So I will give an introduction, and then there will be cases and resistograms that we can discuss. And as we work in very different environments, I'm really looking forward to hearing also from your experiences. And maybe before we start, as we are a rather small group here today, maybe we could do a quick round of introductions. Maybe you can just share your name and your position. I think we're not that many,
yes,
right? I don't.
Yes, of course.
It's good if you start to call people, because.
Okay. Sorry. Yeah. Sevil, would you start?
Yes, of course. I'm Sevil Abdulmohammedian. I'm a pediatrician here in Tehran's University of Medical Sciences, and thank you for joining us today.
Thank you, Koza. Koza cannot hear us today, maybe? Beda?
Yeah, can you hear me now?
Oh, yeah, I can hear you, right?
Yes,
yeah.
Yes.
I'm Dr. Koza Asnashari. I'm a pediatrician and assistant professor of pediatrics at Children's Medical Center, Tehran University of Medical Sciences. We are honored to have you here today.
And Martin?
Hello, I'm Martin Wirpitz. I'm the head of the Pediatric Emergency Department here at the Charité in Berlin, and I'm also a consultant for the intensive care unit, the pediatric intensive care unit.
Then Tokaman?
Louise, I think some of people do not have access to their microphones, or
so they're just listening.
They're not that easygoing in talking English. So I think here we have some colleagues like Dr. Gharib, Dr. Bertha Gharib, and Dr. Gharib, if you have our voice.
We will just dive right in then.
Yes.
So maybe some quick ground rules. If you don't speak, mute your microphone, please. If you have any questions during the webinar, maybe the easiest way to let us know is to use the raise hand emoji, and we will be having this webinar for about 90 minutes. Maybe we'll be done even before that. So just quickly, how did we come up with the topic? We asked the colleagues in Tehran which topics they would be interested in the field of AMR and AMS in pediatrics, and those are the broad topics they gave us. And then we decided to talk about the treatment of antimicrobial resistant and gram-negative infection. And as this is also a broad topic, we decided to divide it in part 1 and part 2. And today we'll start with the part 1, and part 2 might be a future webinar. And then the colleagues in Tehran also gave us some specific questions they would like to discuss and have to be answered. And we will go through those questions during the webinar, and we'll try to address all of them. So this is the agenda for today. I'll give a brief introduction on AMR and AMS in pediatrics. Then we will talk about the very basics of gram-negative bacteria and the defense mechanism like beta-lactamase. And then we will talk about especially ESBL producing antibacterials and MC beta-lactamase producing antibacterials. So we all know AMR is one of our most serious health threats, and the CDC has identified or classified urgent threat and serious threats. And among the urgent and serious threats, there are a lot of multi-resistant gram-negative bacteria. Here also, for example, the ESBL producing Enterobacterialis we are going to talk about today. And we know it's a global health problem, so every region in the world is affected by this problem. And here I just selected some studies from all of AMR or of infections due to multi-resistant bacteria in pediatric patients. So we all know that the main driver of antimicrobial resistance is the rising global antimicrobial consumption. So how can we solve this problem? We all need to be more judicious in our use of antimicrobial use, and what could be helpful. Antimicrobial stewardship programs could provide support to make proper decisions about antibiotic use for the children and adults we serve. So antimicrobial stewardship programs in pediatrics in Germany. Here's the picture of Johannes. He established one of the first pediatric antibiotic stewardship programs in Germany. He also initiated training courses on pediatric antibiotic stewardship programs in hospitals for doctors and pharmacists in Germany. And he also published national guidelines on the conception and implementation of inpatient antibiotic stewardship programs in pediatrics. So as I said, a real expert in the field. And just to give you an idea, I don't know how much you know about antibiotic stewardship programs. Those are the core elements that were published by the CDC, core elements of hospital antibiotic stewardship programs. So what do you need? You need the hospital leadership, you need human and financial resources, you need to appoint a leader of the antibiotic stewardship program. Then, of course, you need pharmacy expertise, and then you need to actually implement interventions. So such as prospective audit or feedback in order to improve antibiotic use. And then, of course, you have to track the antibiotic prescriptions at your hospital, and you have to report those numbers to your hospital team and the hospital leadership. And last but not least, one of the most important elements is also to educate all pharmacists, nurses, or prescribers, or everybody who is actually involved in the prescription of antibiotics in pediatric patients in a hospital. So we have an antibiotic stewardship team here at Charité, was established in 2015, and we're a team of 6 people. We are 4 infectious disease doctors and 2 pharmacists. And I joined the team last year in May, and I'm mainly responsible for the pediatric patients. And yeah, what do? We try to accomplish those core elements. We monitor antibiotic consumptions, then we encourage good clinical practice. We go on weekly infectious disease rounds on the wards, especially on the intensive care wards. We develop guidelines, we educate, we have an infectious disease consultation service, and we engage in clinical studies and international cooperation. So that was the brief introduction on the topic. And now, as I said, I would like to talk on the basics of gram-negative bacteria and beta-lactamase. And now I need your help. I know this is very, very basic, but I would just like you to name some examples of Antibacterialis and some examples of non-fermenter. I know, very easy, I would just want us to be on the same page. Maybe, Koza, you can name one example of an Antibacterialis. Or Martin.
Do you have my voice?
Yes.
Okay, I think I have problems with disconnecting. So as I know some of guys here are a little shy talking in English, let me ask them your question in Persian, so maybe they can write in the chat section. Is it okay? Is that okay?
Of course.
Okay. خب میخوایم بحث رو شروع بکنیم. یه مقدارم بحث رو در واقع چالشی ترش بکنیم. آیا میتونید از انتروباکتر ها نام ببرید دوستان؟ مثلا چت بنویسید برام، فارسی انگلیسی، هر کدوم که راحت.
Do you have my voice?
Yes, of course, Dr. Doctor.
Hi, Dr. Martin. So maybe we
Hello.
can name Klebsiella and hi. We can name Klebsiella, E. coli, and in Enterobacteriaceae is the most famous are Klebsiella and E. coli, and they are the most bacteria that they are ESBL, extended broad spectrum beta-lactamase bacteria. I think our discussion is mainly about them.
Yeah, and then in the group of the non-fermenter, which we won't talk about that much today.
But glucose non-fermenting bacteria, I have not heard about them.
Maybe you have heard about Stewardship, Asymptotic and Pseudomonas.
I know it's in the group of non-fermenting, glucose non-fermenting.
Yeah, Johannes, you can confirm, the microbiologist. This is very basic, but
Burkholderia? Is Burkholderia non-fermenting?
Johannes, we cannot hear you.
Sorry. Yeah, Burkholderia is correct. So the non-fermenting bacteria are, the prototype is Pseudomonas. So these are bacteria that don't ferment, anaerobically digest sugars. This distinguishes the non-fermenters from the enteric bacteria. And as I said, Pseudomonas is sort of the standard, but then, as you said, Stenotrophomonas, Burkholderia are all so-called non-fermenters. But let me extend the question, which ones are more problematic for treating patients? What are you more afraid of?
Acinetobacter is the most problematic one because many times it's just sensitive to colistin. And today I have been informed from our pharmacy that the hospital ran out of colistin.
Mm. So you're correct. In terms of antibiotic resistance, the non-fermenters are more problematic. Often the standard gram-negatives like Klebsiella or E. coli are more virulent. And Acinetobacter is a good example for a bacterium that can cause, or usually causes less disease, less inflammation than, for example, an E. coli or Klebsiella. So it's sort of a double-edged sword. It's on one hand more resistant, but on the other hand, the Enterobacterialis are usually more virulent individually.
Thank you very much. And now let's talk about the defense mechanism of those gram-negative bacteria. So we use beta-lactams a lot. It's one of the preferred treatment regimens for many infectious diseases. And beta-lactamase, they hydrolyze those beta-lactam antibiotics. And the production of beta-lactamases is one of the most common mechanisms of resistance for beta-lactams in gram-negative bacteria. So we should know about them and be aware about them. But before we move on, one more basic question, which antibiotics belong to the group of beta-lactam antibiotics? I hope I don't bore you with this question, but I just want to...
No, of course. So we have the penicillin, we have the cephalosporin.
Meropenins.
Carboponoms.
Yeah, carboponoms in general.
And the monobactams, Adstranam. Okay, great. Thank you. Okay, so this is, classification of the beta-lactamase. So they can be classified as, again, very basic in serine and metallobacter-lactamases, and serine beta-lactamases can be divided into class A, C, and D beta-lactamases. And today, as I said, we want to focus on the extended spectrum beta-lactamase, which belong to class A, and then the second part on the AMP-C, the class C beta-lactamase. Okay, so now we start to talk about the ESBL-producing Enterobacterialis. All of the recommendations, I don't know how to get rid of this, I guess you see this also. Let's see, no. Okay, anyway, all the recommendations I'm going to talk about, they are taken from the guidance on treatment of gram-negative infections that was published by the Infectious Disease Society of America this year. They are publicly available. Yeah, so all the recommendations are based on those guidance. Okay, ESBL producing Enterobacterialis. So what are ESBL? Those are enzymes that inactivate most penicillins, cephalosporins, and astronons. And ESBL producing Enterobacterialis, as you all know, remain generally susceptible to carbapenems. And ESBL, of course, do not inactivate non-beta-lactam agents such as fluoroquinolones, trimethoprim, sulfamethoxazole, and aminoglycosides. But you have to be aware, if you have a bug that carries ESBL genes, there's a high risk that they also have genes that mediate resistance to non-beta lactams. So which gram-negative bacteria can produce ESBL or can harbor ESBL genes? Any gram-negative organism, essentially, they are most prevalent in E. coli, Klebsiella pneumoniae, Klebsiella oxytoca, and Fructus mirabilis. So if you get a resistogram of a gram-negative of an Enterobacterialis, how do you identify an ESBL producing Enterobacterialis? So usually there's no routine ESBL testing, and if you have a non-susceptibility to ceftriaxone, so third generation cephalosporin, this is often used as a proxy for ESBL production. So you have Enterobacterialis non-susceptible to ceftriaxone. This can be a signal or sign for ESBL production. So what does it look like in a resistogram? So this is the kind of resistogram antibiogram we get from our microbiology lab. I will translate the main information. So here material, it's blood culture. Microscopically, they saw gram-negative rods. And then here in the blood culture, they identified E. coli. And here they did some sort of test. So yeah, we ignore this for the moment. And here have the antibiogram. And here you see that cefotaxime and ceftriaxone, so the third generation cephalosporins, they are non-susceptible to, the bug is non-susceptible to cefotaxime or ceftriaxone. So this is a sign that there's this E. coli produces ESBL. So now I would like to address the first question that was that we were asked. So if the antibiogram shows resistant to all third generation cephalosporins, as I just showed you, which antibiotic should we use for treatment? So this question is not so easy to answer because it depends a bit on the type of infection. And in the mentioned IDSA guidance, they differentiate between uncomplicated cystitis caused by ESBL producing Enterobacterialis and pyelonephritis and complicated urinary tract infection. And then all the other infections outside of the urinary tract, for example, bloodstream infections. So what are the preferred antibiotics for the treatment of uncomplicated cystitis caused by ESBL-E? So the guidance recommends that we use nitrofurantoin or trimethoprim sulfamethoxazole. And if you have an ESBL producing E. coli, you could also use oral fosfomycin. And they also suggest to use one single dose of intravenous aminoglycosides because aminoglycosides are nearly exclusively eliminated by the renal route and they're active. I have never treated uncomplicated cystitis in this way, but maybe, I don't know, Johannes, if you have any experience, but yeah, this is something that they mention in the guidance. That is something that you could also think about doing.
we've done that in rare cases, but it's not normal because in most cases you wouldn't use an aminoglycoside by itself alone.
Martin, you have a question? We cannot hear
Could
you.
Yeah, now you
Sorry.
can hear me, I think. Could you please point out if you know that a patient has a high risk of being contaminated by an ESBL and then has signs of an uncomplicated cystitis, would you treat him with oral fosfomycin in a single dose, as we do in patients that don't have this ESBL, or would you give a prolonged treatment over several days? And would you accompany it by an aminoglycoside in that case?
Yeah, it depends also on, so maybe I give my answer and then Johannes gives his answer, so we can discuss. If it's not if the patient is not severely ill, then I would maybe try to, if the patient is above 12 years old, I would try maybe oral fosfomycin and wait for the urine culture results.
And you would just give one single dose and then wait for the urine culture?
Yeah, that's what I would do, but let's see what Johannes says.
For the fosfomycin, yes, I agree. I would do the same. For the nitrofurantoin, this is the antibiotic that we prefer to use in cystitis. But there the problem is often that you have to distinguish if it's really only cystitis or if it's an ascending UTI. And especially in younger kids, that can be complicated. The problem with nitrofurantoin, which is a very good drug and has a very broad coverage of multi-resistant bacteria, gram-negative bacteria, the problem is that it works only in the urinary tract, but not in the tissue. So it's an antibiotic that works in urine, everything that's filled with urine, the bladder. But it wouldn't work if it's pyelonephritis or an ascending urinary tract infection. This is the important caveat. And this is something that you should always remember, because often you look at the antibiogram and then you see nitrofurantoin works, which it often does. And just be sure that it's uncomplicated. It's a cystitis and nothing else.
Maybe you had a question?
Dr. Martin, I have a question about this guideline. Mm-hmm. You have my voice?
Yeah, I can hear you. Mm-hmm.
Yes. This guideline, I think, has a pre-assumption that we have meropenem, vaborbactam, or ceftazidime, avibactam, and other BLBLI antibiotics. But we don't have them here. Most of them we do not have them in Iran. For example, it is said in this guideline that even if the bacteria was sensitive to cefepime, it should not be used, or is recommended not to be used, for out of UTI ESBL E. coli, or colistin should be avoided for carbapenem resistant E. coli. But maybe it is, maybe they consider that we have access to our BLBLI antibiotics. But is it your practice, for example, you do not use colistin for carbapenem resistant E. coli? Because we use it here, and even sometimes we do not have access to colistin. So, for example, today I have a patient with fulminant sepsis, and the responsible germ is Acinetobacter, and it was responsive clinically to colistin. But today I heard from the pharmacy that we do not have access to colistin. We do not have colistin. And I was thinking of using tigecycline, a tetracycline, usually toxic for babies and infants, but we are thinking about using it. Yeah. And we cannot exclude colistin for carbapenem resistant E. coli or cefepime for ESBL E. coli out of UTI, even when there is a sensitivity. So is it also your practice about this guideline?
Yeah, maybe I can say two things. The first thing is that we divided the webinar, like we try to, today we just want to talk about the ESBL and the MC producing Enterobacterialis. And then in the next part, we would like to address the Carboponym resistant Enterobacterialis. And then, Johannes, I want to say something. Yeah. And then, and so maybe we can discuss Carboponym resistant Antibacterialis more in detail in the next session. And in terms of the Asymptotic Bacteremia, maybe we, if you want, we could discuss it also today, because it seems to be an urgent case right now. What comes to my mind if I hear tigecycline for bacteremia, I would be cautious because the serum levels are not high enough of tigecycline in order to treat a bacteremia. So, but Johannes, maybe you want to comment on that.
Yeah, I think it's an important question. And I mean, if you are limited with antibiotics that you have available in your country, colistin, for example, could also be a valuable choice for ESBL. I mean, we tend to think about colistin only in the situation where you have a carbapenem resistance. But of course, I mean, colistin works also well against ESBL, and if you don't have carbapenems available, then colistin is a good alternative and a good choice. I see it as an antibiotic with a lot of side effects, and therefore I'm quite reluctant. It's sort of my last resort antibiotic. And somewhat similar is also the story with tigecycline. As Louisa said, I mean, it's basically a tetracycline with all the tetracycline, doxycycline problems, which is one of the reasons why we don't use it regularly in kids. The other problem is the serum level. It's bacteriostatic. But in certain situations when nothing else works and you don't have a carbapenem available, I think it's a valuable and an important possibility for ESBL, for certain ESBLs.
Thank you. I am saying that we have Asymptotic infection responsive to colistin, but we do not have colistin anymore from tomorrow. And I was thinking of giving meropenem and tigecycline. I know that tigecycline as a tetracycline group is not good for children. We do not use it routinely, but
in certain situations you have to. Absolutely.
Yeah, I mean,
I agree. We have done it as well.
Okay. Which antibiotics have you tested as well? This Acinetobacter, did you test cotrimoxazole as well?
It's an MDR. It's an MDR Acinetobacter. It's just sensitive to colistin, but we only have colistin for the first dose of tomorrow.
Okay.
However, the pharmacy is searching everywhere, but I was thinking the only thing can be tigecycline, and because tigecycline is not effective on Pseudomonas, I was thinking of giving meropenem and tigecycline. I know tigecycline is toxic, tetracycline not good for children, but I was thinking that there is no other choice. And this guideline mainly talks about BLBLI antibiotics, and
but only in the case of carbapenem resistance. Or maybe if you talk today about the ESBL and the MC, and then next time when we talk about the carbapenem resistance, we can take this in consideration, that those antibiotics are not available in Iran, and then we can discuss alternatives. Okay.
Thank you.
Okay, then sorry. Now the group of patients with pyelonephritis or complicated urinary tract infection, as Johannes said, you should avoid nitrofurantoin because the the levels in the tissue are not high enough. So what they suggest is to use either carbapenems, fluoroquinolones, or trimethoprim sulfamethoxazole. And if you start empirically with, or if you start with carbapenem, then and the patient responds and fluoroquinolones are susceptible, then you can consider after a couple of days oral transitioning to ciprofloxacin or levofloxacin or trimethoprim sulfamethoxazole in order to spare carbapenems and not to select more carbapenem-resistant bacteria. And they also say if you have a low potential for nephrotoxicity and you don't have other bacterial agents available, you could also consider to give daily aminoglycosides for a full treatment course, which I have never done so far. Okay, here again, don't use nitrofurantoin.
Yeah, and a quick addition. Always remember that most of the antibiotics are excreted in urine, and the concentration of these antibiotics is very high in urine. So I don't know what kind of antimicrobial susceptibility testing you are doing, but we are doing OICAST, which is sort of the European sensitivity testing system. Can you, somebody indicate? Is that used also in Iran, or?
They told me they use CLSI.
CLSI. I mean, the point that I wanted to make is since you have a higher concentration of the antibiotics in the urine, you can also often use an antibiotic that's tested intermediate. In the situation of a urinary tract infection, a bacterium that's not resistant, but intermediate, susceptible, you can still use the beta-lactams mentioned or the antibiotics mentioned because of the renal excretion and the high concentration of antibiotics that you have in the urinary tract.
Thank you, Johannes. And now the third group of infections, or the infections outside of the urinary tract, such as, for example, bloodstream infections that are caused by ESBL enterobacterialis. So they suggest to use carbapenems as a first line, and then after appropriate clinical response, you can consider transitioning to, again, fluoroquinolones or trimethoprim sulfamethoxazole if susceptibility is shown. And again, as mentioned before, you are all aware, bloodstream infection, we should not use, we should not treat with nitrofurantoin or fosfomycin orally, or amoxicillin clavulanate or doxycycline. Okay, and then another question that was raised before the webinar. So if we have ESBL producing Enterobacterialis, what about piperacillin tazobactam? We haven't spoken about that so far, it wasn't mentioned. Could this be a treatment option? And so piperacillin tazobactam can demonstrate in vitro activity against a number of ESBL Enterobacterialis, but the guidance says that nevertheless, carbapenem is recommended as first-line treatment of ESBL infections outside of the urinary tract, even if susceptibility to piperacillin tazobactam is demonstrated. So what is this recommendation based on? Because it seems a bit strange, no? So this is based on the landmark trial, the Merino trial. I'm sure some of you, maybe all of you, have heard about this. It's a trial that was published in 2018. It's a multi-center trial. And they included adult patients with bloodstream infection caused by ESBL-producing E. coli or ESBL-producing Klebsiella pneumoniae. And the patients were randomized into a group that received piperacillin tazobactam, which was tested susceptible, or and in the other group, they received meropenem. And 391 patients were included, and the primary endpoint was mortality at 30 days. And here you can see that in the piperacillin tazobactam group, 12% reached this primary endpoint, compared to in the meropenem group, was only 3.7%. So there's a risk difference of 8.6%. So this is those are the data, the guidance, or the recommendation is based on. So not to use piperacillin in ESBL bloodstream infection. But again, if you have an uncomplicated cystitis and you started treating this patient with piperacillin tazobactam, and then you get the urine culture back and it shows that it's an ESBL producing Antibacterialis and the patient clinically improved, then there is no need to change antibiotic treatment. So this leads me already to the summary of the ESBL producing Antibacterialis. So again, we said Antibacterialis, you can identify them on your resistogram if you see gram-negative bacteria Antibacterialis with a non-susceptibility to ceftriaxone. Piperacillin tazobactam is okay for uncomplicated cystitis, but should not be used for infections outside of the urinary tract. And then I walked you through all of these different scenarios. And I mentioned some carbapenem sparing regimens and those ESBL producing Enterobacterialis. And now I have 3 resistograms. Maybe we can discuss them, and you can let me know on the basis of what we just heard, what kind of treatment you would recommend. So I give you a...
Louisa, maybe we can have a short period of questions.
Oh, sorry, of course.
Before continuing with the examples, or maybe if everything is clear and nobody has questions.
Excuse me, I had a question, or maybe I want to know your opinion. Here, if we just use, instead of cefepime and zosine, piperacillin tazobactam, if we don't use these 2 antibiotics for out of urinary tract ESBL, E. coli, and we use a carbapenem instead, then we will run out very fast of our antibiotic armor, because then we will, because we just have meropenem, and we don't have, even we don't have meropenem, vaborbactam or ceftazidime, avibactam, other BLBLI. So then if we use carbapenem for them, then I think we will have soon a lot of antibiotic resistance against meropenem. We always prefer to use cefepime or piperacillin tazobactam to avoid to have meropenem as a last resource against antibiotics. So do you think, I mean, is it your practice? You never use zosine for ESBL E. coli outside of urinary tract infections?
We would always change. The moment we have a diagnosis of an ESBL, we would switch from piperacillin tazobactam to meropenem. And this is what Louisa said. This is the Merino trial that really showed that it's not enough. I mean, I know it's often the situation, you have a patient with a fever, you give them piperacillin tazobactam, they improve, fever goes down, CRP goes down, then 2 days later you get the response that it's an ESBL. And then there's always the question, should we stick with what we have and the patient got better, or should we switch? But as Louisa said, and as this is what we do, we would also in this situation switch the antibiotic and give carbapenem.
In terms of...
Yeah, and even in this guideline, it is said that I think that they recommended that not to co-administrate 2 antibiotics for gram-negative bacteria because of the side effects. But we were thinking that it's better to combine them to avoid antibiotic resistance. Because here, if we do that, then we will lose meropenem very soon, because we are.
We have so many. What I was thinking about the use of carbapenems, I think the selection of resistant organism is, as far as I know, also a question of the duration of therapy. So if you start treating a patient with carbapenems, you see the patient clinically improves, then you could transition to a carbapenem sparing regimen, such as oral fluoroquinolones or cotrimoxazole, if their test is susceptible. So you would have a shorter duration of carbapenem treatment. I don't know, Johannes, if that is.
No. I mean, this. If you have a situation where, say, the E. coli is ESBL positive but Cotrim susceptible, I would always use Cotrim to avoid development of resistance. But the question of the development of resistance against the carbapenems, I think is not so much the bacteria that cause the infection, because these you can eliminate. But I mean, the antibiotic has also side effects or selects for resistance in the gastrointestinal tract, on the skin and wherever. And so you're giving meropenem. You wouldn't use it, and it's not the resistance occurs somewhere else. I mean, the ESBL that's susceptible to meropenem will be killed, and the resistances occur in other areas. You get super infection on the skin, in the lungs, in the gastrointestinal tract, etc.
Okay, thank you.
Let me ask you, if you treat those patients with piperacillin tazobactam, what is the clinical outcome? Do you see favorable outcomes, or?
We have had, I think there was favorable outcomes. Yes, it was good. Mm-hmm. So the suggestion in this guideline was very new for me, mm-hmm. and we're afraid of changing mm-hmm. our practice, but I think we have to, because it's a international guideline, we should do that. But I was thinking that because meropenem is the last thing we have, then if we lose meropenem, we are not sure. So I was thinking of combining several antibiotics together. For example, we had a patient with Asymptotic. The patient clinical situation was not that bad. We didn't have colistin. So with consultation from our pharmacologist, I prescribed high dose of ampicillin and meropenem. The clinical situation of the baby was not bad. Maybe it was just colonization, not the infection, and we didn't have colistin. And the bacteria was Acinetobacter, just sensitive to colistin. So I prescribed, with consultation to our pharmacotherapist, I prescribed the maximum dose of ampicillin and meropenem, and the baby had sticky and secretion from trachea, but the condition was good with no fever.
This is always complicated. I mean, as you said, it may have been colonization versus infection. And actually, in the case of Acinetobacter, and I think this is what we are going to talk about maybe in the next webinar. In the case of Acinetobacter, there are these combinations. I mean, there are situations where you are really out of options. Sulbactam seems to be good in Acinetobacter, so this could make sense in certain situations. If this was what cured the baby, we don't really know. If you can't really say for sure it was infected or it was only colonized.
Thank you.
Sorry, excuse me. We have a raised hand here by Dr. Faramas Fatirachian, if you let him.
Of course. I was just ask you.
Thank you. Yeah. Dr. Paturachian, we don't have your voice.
Sorry, this is Dr. Paturachian. I don't have any question now.
Okay, thank you, Dr. Paturachian.
Thank you.
Thank you. So then we maybe can move on and discuss those resistograms. So again, this is that's what the resistogram looked like at our hospital. Here the material is urine, and we have isolated E. coli, and here you see third generation cephalosporins are resistant. So this is a proxy for ESBL production. And now maybe we can discuss what kind of treatment we could think about for this patient, assuming that's an uncomplicated urinary tract infection. Any ideas? Or maybe you want me to call the microbiology lab and ask for more testing. This could also be an option. Do we want to use carbapenems? Any ideas? Martin, help me out here.
Yeah, what is? I think I'd use meropenem, for example, if because it's uncomplicated, but still there's so much resistance on all the other drugs that we could use.
What about this one here?
It shows resistance, doesn't it?
Oh, sorry. I got mixed up. I'm really sorry. I'm really sorry. And what about this one here?
Yeah, might also be an option.
Meropenem. I think meropenem is just sensitive to carbapenems. I think it's just yes, it's just carbapenems that we can prescribe here.
And what about the
Cipro? Yes, Cipro and levofloxacin.
Yeah, that would be what I would use.
Oh yes, I think because I myself want to save carbapenems as our last resource, I prefer maybe levofloxacin with consultation to our infectious disease department, of course.
And if this would have been susceptible, you could have used cotrimoxazole as well. Sorry, that's my mistake. Okay, the next resistogram. Here in the case of pyelonephritis, again, here the material, urine, E. coli was identified, and again, ceftriaxone, cefotaxime resist, non-susceptible. So we have to assume that's an ESBL producing Enterobacterales. Which treatment would you favor? Would you use nitrofurantoin if it was susceptible?
No, it's a pyelonephritis.
No.
When it's something that penetrates the tissue, like a cotrimoxazole or, some kind of fluoroquinolone.
And if you started empirically with carbapenems, then you see clinical improvement, you could transition to cotrimoxazole.
No, we cannot step down.
Oh, you could actually.
We could?
For the pyelonephritis, yeah, you could. To cotrimoxazole. In this case, here is susceptible. Johannes, you want to comment?
I got it.
Yeah, I mean, this is something lots of people think about cotrimoxazole as an antibiotic that you use for uncomplicated urinary tract infection, but it's a very potent broad spectrum antibiotic. And I mean, I'm old enough, before we had a lot of drugs for MRSA. We used it quite often also in a patient with MRSA. So you can give it IV, quite high dose, and it's very potent. So in a situation like here, where you have a susceptibility, perfectly fine. Alternative, again, could be ciprofloxacin, again, susceptible here as well. And I would prefer all of these before the carbapenems, for exactly the reason that you were mentioning. You don't want to cause resistances to meropenem. This is situations where you can avoid meropenem or carbapenems altogether.
Maybe you can comment, or maybe you just said it, but I didn't hear it, whether or not to use cotrimoxazole orally. You would start maybe IV and then transition it to oral?
I think this is something that you can do. It has a very good oral bioavailability, and it could be, you could start IV and then eventually give it a PO. That's probably what I would do.
Okay, then maybe here, did you have any questions? No. Okay, this is the last example. So here we have material blood culture. You see, German is very similar to English. Blood culture, they microscopically, they identified gram-negative rods, and they identified E. coli. Again here, well, our lab does this ESBL testing, but if that's not available, again, you check the third generation cephalosporin, ceftriaxone, cefotaxime, they are non-susceptible, so ESBL producing Enterobacterales. And now the question is, okay, you have a serious infections outside of the urinary tract. What kind of treatment would you initiate?
So if it is a very serious infection, we start IV, and between meropenem and levofloxacin, I think there is no difference. However, I prescribe meropenem.
Me too. And then I would transition to oral treatment at some point. For how long what would be the treatment duration for E. coli bacteremia in your hospital? Would you treat for 10 days, 14 days?
If it is a serious sepsis in a little babies, normally in intensive care, we continue. We give it between 2 to 3 weeks. Better for 3 weeks.
Okay. Johannes, maybe you want...
Yeah, 3 weeks I think is long. I mean, we would do 2 weeks, but not 3 weeks. Maybe I missed it. Would anybody give ertapenem? Do you have it in Iran?
No, we don't have.
Okay.
What about you? Would you
just
use
have
it,
meropenem and imipenem silastine, and meropenem and imipenem silastine, the only carbapenem we have here.
And Johannes, would you use ertapenem?
Well, it would depend. I mean, it's tester susceptible. It's a carbapenem. You could give it from the carbapenems. It's the weakest. So I think it would depend a little bit how the kid would do. Mm-hmm. And of course, I mean, as everybody else, we use a lot of meropenem. We probably would start with this, but it's smaller in the spectrum. It's less likely to select resistances. So it's you can think about it. Honestly, I don't know if it's licensed for babies. This was a baby, right?
Let's assume it's a baby. I think I'm not sure. I'm sorry, but Martin, I saw your hand. I want to point out to this one here, because here you see piperacillin tazobactam, and the MIC is below 4. So by definition, it should be susceptible. But what our microbiology lab does is it puts an R here. And this is also something new, and maybe, the background is the other results of the Merino study. But this is something particular, I think. I don't know. Okay, Martin.
Talking about the MIC, could you point out your view or how important you would judge the TDI on using carbapenems? We usually do when we treat severe infections such as bloodstream infections. We usually do a TDI with monitoring the levels of meropenem, for example. Could you say how important you rate this?
Mm-hmm. So we started doing therapeutic drug monitoring in some of the beta-lactams at ICU, and they're not, so in the adult medicine, there is some data that show that this could be beneficial, that you want to achieve a level 1 to 5 times of the MIC of the bug that you identified. But yeah, in pediatrics, the data are still sparse, I think, in this field, but we still do it. I don't know, Johannes, if you want to comment on that, if you...
We have done it in a couple of patients, so but it's still complicated also in our hospital. We have theoretically the possibility to do levels, but we don't do it on a routine basis. Although I think it would be a good idea, and we should have it more readily available. Takes a while. It's done in a lab that's a little bit remote. You have to transport things there. It has to be frozen. It's a hassle. But in a seriously sick, septic kid, I think it may be a good idea.
Also, if the kid has a risk for renal insufficiency, and yeah, Martin?
And talking about IV dosing of the drug, is there an advantage of giving it as a continuous infusion as compared to prolonged dosing or the non-prolonged dosing? We know that prolonged dosing of maybe 4 or 6 hours is beneficial, but is there a beneficial effect of continuous infusion of carbapenems?
Johannes, you have to answer this question.
I mean, there is clear cut. The longer the interval is that you are above the MIC, the better it is for the beta-lactams. If the 4-hour infusion or the continuous infusion does really result in a lot of additional effect, I don't know, and I don't think so. I think for most situations, the prolonged infusion should be as good as the continuous infusion. And continuous infusion is always also a big problem in the intensive care unit. You need an extra lumen. You have to change because the antibiotics are not stable at room temperature for such a long time. So it's also a hassle. So long story short, 4 hours I think is a good compromise.
And in the Tehran, do you give the carbapenems over 4 hours, or at the intensive care unit? We don't know. Okay.
I think Dr. Gharib should answer that.
I don't think so.
We don't use it. We don't use continuous infusion because, as Professor Hoppner said, we need the lines, so we cannot give one line to a continuous infusion in intensive care unit.
And prolonged for 4 hours? No.
No, we don't give infusions. It's infusion for 1 hour.
For 1 hour,
not the
okay.
continuous one.
Okay. All right. So, how much time do we have left? Half an hour? Are you still with me?
Yes,
I know
half an hour.
It's been a long day in Tehran. It's already 2.5 hours later than here, but maybe I can walk you quickly through the last topic, the MC beta-lactamase producing antimicrobials. I hope you don't fall asleep, but let's see. So beta-lactamase, we spoke about the serine beta-lactamase class C, the MC producing antibacterialis here. MC can be produced by a number of antibacterialis and the before-mentioned non-fermenter. And there are basically 3 mechanisms of resistance. And what I want to focus on today is the inducible type of resistance. What does it mean, inducible? It means that the bacteria is initially susceptible to certain beta-lactam agents, such as, again, the 3rd-generation cephalosporins. And they become resistant to those antibiotics after they are exposed to those beta-lactams. And this induced MC expression can be can also occur already after very few doses of ceftriaxone or ceftazidime. And the non-beta-lactams, they cannot induce this MC expression. So you have the antibacterialis with a risk of MC expression. They can be initially ceftriaxone, ceftazidime susceptible. Then you treat them with those antibiotics, and then all of a sudden they develop a secondary resistance to those antibiotics. So this is called inducible MC expression. So then the colleagues there and they asked us, okay, but how can we recognize or predict MC producing bacteria? And if we isolate them, what would be the best treatment? So it would be great if we could know which bacteria have the highest risk to produce MC beta-lactamase. There are not many studies, but those three antibacteriales are identified that they have a moderate to high risk for clinical significant MC production. And I'm a visual kind of learner, so I put some images. The first one is Citrobacter freunderi, and freunderi, so citrus fruits here, and freunderi, Freund in German means friend, so that's why there are three of them, because there's also Citrobacter coseri, which is not an MC producer, so it is not at a high risk for MC production. So Citrobacter freunderi, number one. Number two, Enterobacter cloacae, so GI tract cloacae, and then here Klebsiella aerogenes, air travel. Yeah, aviation. So those three have a moderate to high risk to produce MC due to inducible MC gene. So what does it look like? Here we have again the resistogram from our lab. This time it's tracheobronchial secretion. They macroscopically saw gram-negative rods. And then here Klebsiella aerogenes. And now that you know, okay, this is one of the three that have a moderate to high risk for MC production. And you check the resistogram. Oh, okay, here they're still susceptible, but you know that those bugs have a high risk to become resistant to those antibiotics under treatment. And this is also here, our lab, they inform us about the risk, and they say, okay, if you have this kind of bacterium, you should not use cephalosporins. So again, here's summary: Citrobacter freunderi, Enterobacter cloacae, Klebsiella aerogenes. You should avoid third generation cephalosporins. Again, if it's an uncomplicated cystitis, you might try it. And then what about cefepime? So for all of you who don't know, cefepime is a fourth generation cephalosporin. It's a broad spectrum cephalosporin. In the gram-positive spectrum, it includes MSSA, and in the gram-negative spectrum, it includes Pseudomonas aeruginosa. So cefepime does not, so the potential of cefepime to induce MC production is relatively low, and cefepime is relatively stable against MC. So even if it is if the production of MC increases, cefepime can be still used. But there's one caveat, you have to check the MIC. So if the MIC, so this gets a bit tricky, is very low, then you're safe to use it. But the guidance says if the cefepime MIC is high, then you should rather use Carboponoms and MC producing Enterobacterialis. And the idea behind this is that if you have a high cefepime MIC, then you have a high risk of ESBL production. And cefepime should not be used, or is not optimal for the treatment caused by ESBL producing Enterobacterialis. And then there are many questions that need to be answered. So far, there are no RCTs available that look at that compare the treatment with cefepime versus carbapenem in MC producing Enterobacterialis. And again, the question about pilpiracillin tazobactam, could that be an option? And again, as in the group of the ESBL producing Enterobacterialis, the guidance says, no, you should rather not use it for serious infections. And those bacteria that are at high or moderate risk of inducible MC production. And one of the reasons is that tazobactam is less effective and at inhibiting the MC hydrolysis than the newer beta-lactam inhibitors. So piperacillin tazobactam in MC producing Enterobacterales is not suggested. What about the newer beta-lactam? So this is, I don't know if that's available in Iran. Ceftazidime could be an option, and also those newer beta-lactam, beta-lactamase combinations. But the guidance also said, maybe you should not use it. You should reserve those treatments for bacteria that are non-susceptible to carbapenems. So in order to spare those newer antibiotics, in order to avoid rising antimicrobial resistance in those new antibiotics. And what about non-beta-lactam therapy? Could that be an option for MC producing Antibacterales? Again, like in the ESBL producing Enterobacter cotrimoxazole, fluoroquinolone, so it's basically always the same. There are not so many options. They can be considered. And you should always of course, take into account the clinical status, and you have to think about the source of infection. Then you have to make sure that the patient is able to absorb or consume the oral antibiotics. And of course, you have to check the susceptibility. And for the MC producing Enterobacterales, if you have an uncomplicated MC, Enterobacterales cystitis, the options are the same as for the ESBL producing Enterobacterales. So as a summary, that was very quick, but those are the main facts that you might want to remember. What are the 3 gram-negative bacteria that have a moderate to high risk for clinical significant MC production? Citrobacter findri, Enterobacter cloacae, Klebsiella aerogenes. So if you see them, you should avoid ceftriaxone or ceftazidime, even if they initially tested susceptible, because they can become resistant. And then piperacillin tazobactam is not suggested. And the treatment options include carbapenems or non-beta-lactams. And yeah, so are there any questions on MC producing Enterobacterales before we discuss our final resistograms?
Excuse me, Martin. Do you suggest to use antibiotics, the proper antibiotic, alone or co-administer with something else in serious infections in intensive care unit? For example, we normally prescribe piperacillin tazobactam with an aminoglycosid. Do you is the same in your practice?
You mean as an empiric treatment in patient where you suspect a sepsis?
Empiric, or even when the germ is susceptible to some antibiotics, we co-administer instead of single treatment. We co-administer. In the guideline, it is. I think I'm not sure. It is said that it's better avoid co-administration. I think because of the side effects. Yeah. But we heard that it's better to co-administer for avoiding resistance.
For avoiding, this is something Johannes has to comment on, but as an empiric treatment, we usually only use one antibacterial agent when we suspect sepsis. And then it depends also, if it's not empirical but directed therapy, you tell me whether or not you can use or should use piperacillin if you have Citrobacter or Enterobacter or Klebsiella aerogenes. So in this cases, when you have a severe infection, we would use carbapenems. But maybe Johannes, you can comment on that.
Yeah, I mean, in general, I would also give only one drug. You have an E. coli, ESBL. I would give ciprofloxacin or meropenem mono. Although, you know, sometimes, and I think this is not really based on good data, but sometimes in a situation when the kid is really severely septic, I sometimes start with 2 and I try to use antibiotics that are synergistic. So you could do, for example, a beta-lactam and an aminoglycoside, or a beta-lactam and a ciprofloxacin, or a quinolone. But that is not really based on really good clinical data. This is sort of what we call in Germany cold feet. You're sort of afraid for your patient, and then you do that. And as soon as the patient stabilizes, I would remove the second antibiotic, and I would only use one. Development of resistance, usually in a clinical situation where you treat a clear-cut septicemia or pneumonia or so, I think is not such a concern. I mean, this is when you do that on for a long period of time. This is like the situation in tuberculosis where you treat for a month or so. Then you want to have something else to avoid development of resistance. But for a 1 week, 10-day, 2-week treatment, I wouldn't be concerned.
Thank you.
Thank you.
And if in antibiogram there is sensitivity, the bacteria is sensitive to both cipro and levofloxacin, is there any preference between these two antibiotics?
I would use levofloxacin or moxifloxacin for gram-positives and ciprofloxacin for gram-negatives. That would be my preference.
Okay, thank you very much.
Thank you, Johannes. Any more questions? If not, we can maybe, how much time we have left? 15 minutes. Okay, I have three more resistograms, and then I let you off the hook. So this is here, resistogram again, material urine, and we have identified Citrobacter freunderi. Is this an Antibacterialis with a moderate to high risk of MC production? Yes. Okay. So, but here you can already see it already is resistant to third generation cephalosporins. So you don't have the clinical dilemma to decide whether or not to treat with third generation cephalosporins. What would you use instead?
We can use the cefepime according to the MIC.
Mm-hmm. Yeah.
And even if it was susceptible to third generations, we wouldn't use them.
The MIC was above 2, you said? Sorry, I didn't hear you.
Yes, the MIC is above 2, so is below 2, so we can use the cefepime. And even if it was susceptible to third generations, we couldn't use them.
But is that the drug that you would use? Look at the rest of the antibiogram. This is a urine. This is not pyelonephritis. This is something that you could treat orally.
Okay, but we can use the,
So,
do we have nitrofurantoin here? No, we can use the cotrimoxazole, yes.
Ciprofloxacin would work.
Yes.
But
So small.
But you mentioned something, cefepime. So at our hospital, it's not. We have to ask the lab to test for cefepime. But Johannes, correct me if I'm wrong. But if the third generation cephalosporins are tested susceptible in the urine, then you could use cefepime even though you don't have the test results available. Yeah. Okay. Okay. Next one. This is again tracheobronchial secretion, and we have identified Enterobacter cloacae. Again, you remember the picture, and what is going on here? It's already resistant to third generation cephalosporins. So we assume this is nosocomial hospital-acquired pneumonia. And it's not only a colonization, but a true infection. What would be the treatment options?
Levofloxacin, I think.
Levofloxacin? Okay.
I can go with carboponoms.
Or ciprofloxacin, since it's a gram-negative bacteria, you could also use ciprofloxacin or the carbapenems.
It's gram-negative. Oh yes, it's gram-negative. Yes, then it's
cypro. Yeah.
And cefepime is resistant, right? So here MIC is very high, so you cannot use it. Okay, and then the last one. I don't know what material this is. Looks like urine. So we have here identified E. coli, and we have identified Klebsiella aerogenes. So can somebody tell me if the E. coli is ESBL producing or not?
Yes, it is. It is resistant to all of cephalosporins.
Okay, and if you hear the name Klebsiella aerogenes, what kind of beta-lactamase do you have to be concerned about?
Tazocine, we should not use tazocine as mentioned in the guideline, and we should use maybe, I think, meropenem.
Okay.
I don't know if it is sensitive to, it's not sensitive to anything else, so it's just meropenem, I think.
So you get the 2 bugs with meropenem, because here is cotrimoxazole resistance and ciprofloxacin is resistant here, so there's only one treatment option as far as I can see this here. Yeah.
This is the situation where you might think about using gentamicin, susceptible for both. It's a urinary tract infection. This is a situation where you could try to use an aminoglycoside. As I said, I mean, we don't do it on a routine basis, but in such a situation where you end up otherwise using a carbapenem with no alternative, I think that could be attractive.
And if it was urosepsis, you would not use
aminoglycoside. Then I wouldn't do it. Yeah.
Okay.
And if this was just colonization, if this patient didn't have any signs of infection and it was just they just showed these 2 bugs in the urine, and he doesn't have any fever, he doesn't have any elevated blood signs of infection, would you treat it or no?
My favorite question. No.
Because it's a patient that is hospitalized and it's like an asymptomatic bacteriuria, but it's in a hospital setting. So treatment or no treatment?
It's 2 bacteria, which is not usual for urinary tract infection. It's a Dauerkatheter. It's a indwelling catheter, so it's something that's prone to be colonized.
Right.
But on the other hand, it's the 10 to the 5 bacteria. I think it depends a lot on what you're saying. So if leukocytes are high, if the patient has leukocytosis, CRP, something, then I would treat it. If all of is not, first thing would take out the catheter and then do a control. Very good point.
Okay, this was the last resistogram, and we are actually at the end of the first webinar of part 1. And yeah, future webinars could be on different topics. Yeah, that's about it. This is the end of our webinar. I hope you enjoyed it.
Thanks a lot, Dr. Martin and Professor Hoppner. Thank you very much.
Yeah, it was a pleasure. I hope you could benefit. And let's just see if you are interested in continuing. I think there's lots of topics that we can talk about.
If you're interested in continuing those webinars, maybe we could also discuss patients from the hospitals, or you can present some of your infectious disease guidelines. So yeah, could be an idea.
Yes, yeah, yes, of course.
Thank you very much.
Thank you so much. Yes,
thank you very much.
Great, great examples of these antibiotics that we have some questions about that. So I think we can discuss about the date of the next session because it was great. And I really, I was taking notes actually. Thank you so much. Kosar, if you have any comments or any idea about the next session, or
no, I think we can arrange the plan for next session later. Yeah, it was great. Thank you very much.
Thank you all for joining.
Thank you
have
for
a lovely
joining.
Dr.
evening.
Martin, Professor Hubner, and thank you, Martin. So see you later.
See you soon.
Bye-bye.
Have a good night.
Bye bye.
Bye bye. Johannes,
Bye.
vielen Dank.
Ja, war gut.
Wir telefonieren. Tschüss.
Ja, ciao.